Hello, this is Dr. Dorothy Merritt, and today we're going to go through 9 or 10 case studies of EDTA chelation in various patients with various medical problems or metal overload. Case 1 was a 50-year-old asymptomatic man who had an extreme positive family history of coronary artery disease with all of his brothers having heart attacks in their early 50s. He went to a cardiologist who begrudgingly put him through a stress test, and it was positive. He did a cath, which showed a 50% distal lesion and narrowing of the LAD. He presented to, and then they did as part of the stress test, they did a nuclear stress test, and you can see he brought the little tape arrows. The little black spots there where blood is not getting to where it needs to go. So he did 50 EDTA chelations over the first year. This was his repeat stress test the next year. It's all clear. All the ischemia is gone. His cardiologist had put him on aspirin, ACE, and statin, and then I did the sodium EDTA. I also measured lead in his urine over time, and it went down quite considerably, so we reduced his body burden of lead at the same time as treating his coronary disease, and had a very good outcome. One of the things I want to emphasize, because everybody does these urine toxic metals, and there's it's very litigious, and you cannot diagnose lead toxicity based on one of these. Okay, you can only say that there's increased body burden suspected. I do find that it does help to do these over time, and because it does show that you're not being re-exposed. Okay, if your numbers keep going down over time, then you got rid of what you had, but if you've got current exposure, you need to be very careful. Anyway, so depending on, like this lead here looks like it's really high, right? But these reference ranges are for non-challenged, but they use the same reference ranges for non-challenged as in challenged. So when you have 8 or 10 times more coming out in a normal person of lead, then, I mean, with treatment, then it looks like this person might be toxic. The other problem is skinny white women with no bone mass have higher numbers because of the ratio. These are ratios to creatinine. Well, if they don't have enough creatinine because it's low, because their muscle mass is low, then it artificially makes this number look high. So these tests have to be taken with a grain of salt. You can't just look at them. I actually, on the lead, this is a teaching slide I use, I actually calculate the micrograms of total lead in the collection. So it's not really this that is important, it's this. This is a case of 58-year-old obese white female non-smoker, mild hypertension, who presented with an acute MI, and as you can see, nice little tombstones all the way across the EKG. She had done a physiological body scan over the past 6 years, and we knew that her arteries were tight, and then she treated her hypertension and they came down normal. Same with the small vessels. So here she is looking really good, except there was one thing: her hypercoagulability was very high the end of December of 2015. And sometimes we just blow these numbers off because that doesn't make sense. Everything else is looking good. Well, in this case, 5 days later or 6 days later, she had a STEMI and a 2-inch clot, which knocked off her LAD at the top, and then you can see it came back. And she had done maybe 10 EDTAs in the past, but after the STEMI or the post-MI treatment, she did 40 treatments, and then every 2 to 4 weeks for a couple years after that. Physiological parameters, returned to normal, and no further incidents, and her repeat cath actually showed regression of some 20 and 30% lesions that were there in a couple of the vessels. So this presented as a gallbladder attack because it presented on the right side, and it attacked her at 5 in the morning for 3 or 4 days prior to actually having the big one. This is a 69-year-old white female who came in asking for chelation in 2017. Her blood level was 4. She had a history of cataracts, osteopenia. She'd been using homeopathic treatments. Her T3 was elevated because she was using Armor, and Armor has a higher T3, T4 ratio than humans. And she had, on this little lead test that I do, 13 out of 30 positive on the review systems. She had 43 micrograms of lead calculated on her 24-hour challenged urine, as well as elevated cadmium. She had 55 to 75% carotid bulb stenosis in 13, and after treatment, she had 40 to 50%. And that's just a regression with her little homeopathic nattokinase red rice yeast. And then in 2018, after chelation, her right carotid bulb was less than 15%, and her left carotid bulb was less than 15%. So again, this is a carotid stenosis case. We reduced the blood lead level by changing her Armor to Synthroid plus cytomel in a 15-to-1 ratio, which is the human ratio. Anyway, her blood lead level went down below 1, and she's doing well. This is an interesting case of a 59-year-old white female that presented with neuropathy, and on her urine metal challenge test, she had high antimony and lead. And you're going, where did the antimony come from? Well, turns out, after a little environmental sleuthing, her Franzio wine in a box, the lining was full of antimony and lead. Lead was 11 times the EPA maximum amount for drinking water, and the antimony was 3 times the EPA number. And she was treated and improved and did not drink wine out of a box anymore. A case of mine, a gun range enthusiast that came in with several blood lead levels that ranged from 37 to 47. This is my lead H&P, and he had his nitric oxide stick showed low. His blood lead level was 47 to 37. He had 9 out of 30 on this review of systems. He had, and it went down to 5 out of 30. This was 5 months in treatment. We did a bone density on him, and it was low, and his testosterone was low, so we gave him testosterone to help both of these things and to reduce his bone turnover. This is on his urine test, which I'll show you in a minute. He went from a true OSHA level of 778 micrograms of lead out in a 24-hour period. And then a year later, approximately, he's down to 27 with treatment. This is his urine lead test, which was way up there, calculated out to the OSHA level of 774. And here it was down to 27.2. It still looks like it's in the high range, but this is why you have to do the actual calculations like I showed on that previous slide to see how far you've come, because just that versus that doesn't look like it's a whole lot, but it actually is. I don't know if it's Texas or it's just we have a lot of lead toxicity from retained bullets. Had a sheriff deputy whose blood lead level was 10, and he had 700 retained pellets from a frontal lobe getting blown off at a restaurant during a robbery. And he's now working as a process server. His metal concentration was worsening. He did 2 rounds of EDTA, and it was much better. And unfortunately, workman's comp wouldn't pay for it because it wasn't OSHA levels. And several years later, his blood lead level was back up to 7, but he didn't want to get stuck anymore, and his wife wanted him to do it, and workman's comp wouldn't pay. So I don't know how he ended up, but I know initially he had a very good result. I had another 45-year-old lady who had retained bullet fragment in her sinus area. Her blood lead level was 5. She had chronic migraines, and Aetna actually approved the calcium EDTA, and when the blood lead level got below 2, she would be asymptomatic, and when it would rise above 2, she'd have her migraines again. So after 3 rounds of 15 treatments over 2 years, with time in between, she had no more elevations in her blood lead level and no more migraines during the follow-up I had for a couple of years. Of retained bullets. This 50-year-old biologist was accidentally shot by a friend during a bird hunting trip. 150 pellets retained in his soft tissues and 4 in his joints. Blood lead level got up to 38 after several months. Occupational med specialists in Dallas didn't recommend chelation because it wasn't 40. The orthosurgeon took out 4 pellets in joints, but there was no improvement in his numbers. He had hypertension develop and cognitive decline, although neuropsych testing was average, but he was a high-functioning scientist and had a higher test result probably before this, so average was not good for him. He found a practitioner in his area. I don't recommend this, but they did IV calcium EDTA push with 2,500 milligrams of IV push glutathione, which must be the key to not nuking your kidneys with that much of a bolus dose of calcium EDTA. His blood lead level did go down to 4 within a year, but he took 6 weeks off, and it was back up to 9 after his Thanksgiving Christmas holiday. We tried some EDTA suppositories that are fast-acting and, long-acting, and, he tried the fast-acting ones. He also tried the long-acting ones and adding DMSA, but he restarted the IV calcium EDTA, and now he's down below 4. Another patient was a 68-year-old man with peripheral neuropathy, generalized pain requiring narcotics, and a blood lead level of 9 due to retained bullet pellets in his foot. Previous EDTA had helped, and he reduced his pain meds, but he switched to a Medicare Advantage plan that had a huge deductible on IV services, and so at some point he restarted his EDTA and he got better, but he didn't continue it because of the cost. This patient is a 56-year-old gunshot woman, victim, with many retained pellets after a murder attempt with her ex-husband and mother, who had a blood lead level of 19 when she was referred to me. Treatment helped the neuropathy, the hypertension, the headaches, and general overall well-being. A recent attempt to keep the blood lead level down by adding Chemet is ongoing at this time. Now Chemet's not available, and she's on a Medicare Advantage plan that won't pay for compounded medicine, and she does not have the funds to get it, so I'm not sure where we're going to go with that one. That shows that with retained bullets, the fragments that are in or around a joint are associated with higher blood lead levels, and many physicians and orthos are just not willing to take out these retained bullets, but my recommendation is as soon as you get one, get it out of you, because you'll be having problems, 10 or 11 years later from lead toxicity. This is a very interesting case of a 50-year-old white female who's disabled based on a nuclear plant exposure to beryllium. We had to find a special lab to measure the urine for beryllium. She had developed autoimmune thyroiditis, chronic fatigue, neuropathy, depression, fibromyalgia. She was positive for the B27 genetic thing. Her post-EDTA urine spill was 20 times baseline after the calcium EDTA, so we knew that it took it out. 30 treatments later, over the past year, and the patient was 100% improved, still has hair loss and autoimmune thyroiditis that flared when the pandemic shut down our chelation suite, and she couldn't get her treatments, but she restarted and started improving again. This is a case, and it's not uncommon, of cobalt chromium toxicity from these metal-on-metal hips, which have been recalled and the source of many lawsuits. Had a 67-year-old man who, with a failed recalled hip, present for consultation. His serum cobalt level was very high. His challenge was very high. He had sensomotor neuropathy in his legs, bilaterally proven by EMG. He did 15 treatments of calcium EDTA. We put NAC and methylfolate, B12 vitamins. Creatinine dropped to less than 1. Neuropathy mostly resolved. Patient delayed getting his hip replaced. He just emotionally did not feel he could go through it. A year later, he presented with thyroid storm, worsening of AFib, maximal endocrinologist intervention with meds. Steroids did not resolve the storm. He was just extremely cushingoid. 3 treatments of EDTA given weekly stopped the thyroid storm, allowed the taper of steroids, and the creatinine and neuropathy went back down. He finally got his hip replaced in 2017, and 5 years later, his cobalt levels are normal, and he is stable. So the treatment for cobalt is EDTA, cysteine, or liposomal glutathione, and you can see how much cobalt. I mean, you don't need to do the IV, it does a little bit more, but liposomal is available orally, and there are other ones that NAC turns into glutathione, so we use both. Okay, this is just a nice little thing done by one of my colleagues showing the different organs that different metals approach and how we're all very, very toxic from these different metals. Thank you for your attention today.